Hi guys and welcome to the Unacademy NEET PG YouTube channel. Now we've got something very interesting for you. Every Tuesday at 8 pm, so it's a fixed time slot of 8 pm, I repeat every Tuesday, we will bring to you a session known as Images Decoded. Now what will we actually cover in this session? All of you always have a lot of trouble understanding the pink and blue and the world of pathology and the colors involved in it. So I decided to simplify this for you and divide the images that we have in this subject chapter-wise. So every session, which will be a short session of 20 to 25 minutes, will have the images of one particular topic. So the topic with which we are starting this session and the topic for this Tuesday session is GI pathology. So obviously all of you know that GI pathology is something that will cover every organ, and that is how we are going to go organ-wise. We'll start with the images of esophagus, then we'll go on to the images of gastric pathology, and then we'll deal with intestinal pathology. And in this, for every organ, we will divide it into, again as I said, in an orderly, systematic manner, we will divide it into non-tumorous, that is non-neoplastic, as well as tumorous, that is neoplastic conditions. Also, for every image or for every disease, we might have to take help of certain special stains. So we will study those special stains as and when required. And in some diseases, all of you know slides are not enough. Radiological correlation, especially when you're dealing with GI path, radiological correlation is also important. So maybe some very characteristic appearances like the bird beak appearance, the apple core deformity, the string sign, the lead pipe appearance. So all of those classical images that you also need to know from the radiological point of view would be covered as well. So it's going to be a nice integrated session that we are going to have out here. So without wasting any further time, let's begin with the first session under this series of Images Decoded. Just to remind you guys, every Tuesday, 8 pm. So as I said, we'll be going organ-wise, and the first organ that we are considering is esophagus. Let me give you a list of disorders we'll be doing under esophagus. We'll be talking about achalasia cardia, we'll be talking about Barrett's esophagus, and then we'll be talking about tumors of the esophagus, that is squamous cell carcinoma and adenocarcinoma. So these are the list of images that you have to know under esophagus. So let's begin. The very first disorder with which we are going to begin our discussion of esophageal pathology is achalasia cardia. Now, what do you appreciate in achalasia cardia? All of you know that there is an unopposed action of acetylcholine, because of which the esophagus is in a constricted state, right? And I guess it is very well appreciable over here. This is a barium study picture that we have. The upper end, the upper part of the esophagus is dilated, and what you see in the lower part, the esophagus is constricted. And this has a very classical name to it. All of us know it better by the bird beak appearance, because this lower end of the esophagus looks like a bird beak. Let us have a more magnified image of the same. So this is what you can appreciate best. The lower end of the esophagus is constricted. Now this is achalasia cardia, and all of you know, although this I said that this is an image based session, but you know, a theoretical question here and there would not harm anyone. So if someone asks you the treatment of achalasia cardia, there are two aspects of it which all of you need to know. Number one, you know there's an injection of botulinum toxin, because this constriction is happening because of the unopposed action of acetylcholine. So giving an injection of botulinum toxin will decrease that effect of acetylcholine, number one. And number two, the surgery, which all of you read under the esophageal chapter in surgery, that is Heller's myotomy. So these were just additional points that you have to know for achalasia cardia. This is the image that you get most commonly. Let's go on to the next picture. The next picture is a very famous one, which all of you know, where one epithelium of the esophagus is going to change into another epithelium. And this is just a small GIF for you to have a visual memory. So what all of us know is that the normal epithelium, what you see above, the normal epithelium is of the esophagus is squamous epithelium. And at this junction, at this gastroesophageal junction, do you notice that this, first you can see the normal epithelium, now it's changed. You can see this red velvety epithelium taking over it. So what is that change? The normal epithelium was the squamous epithelium, and it has now changed into the columnar epithelium, and to be more precise, this is the intestinal columnar epithelium. So now having this brief, why did this happen? Because contents from the stomach were going up into the esophagus. We were dealing with gastroesophageal reflux disease. Let's look at the histopath of this, guys. It's a very simple picture. You just need to focus on two parts of this picture. So number one, as you can see right over here, this part, entire part, this is the squamous epithelium. And then what is it entirely changing into suddenly? This is changing into, do you notice these round structures? These round structures out here? These are the glands. So please remember, this squamous epithelium is changing into these glands, that is the columnar epithelium. And if you look very closely in these glands, you will be able to appreciate the goblet cells. So in these glands, when you look within these glands, you can appreciate tiny cells called the goblet cells. Let me show you a better picture. So how do you identify a Barrett's esophagus? You divide this picture into two parts. Number one part, you can very well appreciate this squamous epithelium, right? And then what is it changing into? So the transition is happening from squamous into glandular epithelium, intestinal columnar epithelium. And if I want to confirm these goblet cells, that's the next picture. So a very important image-based question that you get in Path. When I want to confirm goblet cells, number one, I should know what do goblet cells contain. And they contain mucin. So if I want to point out mucin, what is the special stain that I will use? All of you know that. We will go in for Alcian blue. So now I want you to appreciate this picture, which has an altogether different color than the usual HNE that we see in pathology. So look at this topmost layer, and then over here, for example, let me point out this cell. Do you notice this cell, this vacuole is filled with this blue color material? Why blue? This was actually mucin, and I have put a special stain called Alcian blue. So this is how I've confirmed it. Let me show you an even higher magnification of the same. So very clearly, I hope everyone can appreciate that over here I'm seeing a cell which is bluish because of Alcian blue, because it contains mucin. So this was the characteristic histopath finding that you see in a case of Barrett's esophagus. What about the endoscopic finding of the same? So quick recap of that as well, something that you do more in the clinical subjects, surgery especially, but very important image. So what do you see out here? This is an endoscopic view, and very clearly you have two colors that you appreciate. One is this pale pink color and the other is this nice red velvety color. So this pale pink color, this is the normal squamous epithelium of the esophagus, which all of us have. And this red velvety mucosa, these, do you notice these irregular red velvety mucosa? These are the areas where the metaplastic changes occurred. You see that labeled as Barrett's esophagus. So that is an endoscopic profile that you see in a case of Barrett's esophagus. I hope everyone remembers that this disease is of utmost importance because it is precancerous. You do not treat it, patient can land up with esophageal cancer. Okay, so that brings us to the next two pictures. When I'm talking about esophageal cancer, there are two cancers that should come to your mind. One, squamous cell carcinoma, because the normal epithelium of the esophagus is squamous epithelium. So the first thing that will come to your mind is squamous cell carcinoma. And this trick will not only help you identify squamous cell carcinoma of the esophagus, but also squamous cell carcinoma anywhere in pathology that comes to you, be it the skin, because skin also has squamous epithelium, be it the oral cavity, that also has squamous epithelium, anal canal, that also has squamous epithelium. So anywhere you talk about squamous cell carcinoma, this similar picture is going to come up to you. How do you identify? First point, you notice that this is a usual pink and blue slide. So this is the HNE section. The first thing, you don't see the cells arranged in a sheet, right? They're not arranged in a sheet. They are arranged in these islands. Number one, then number two, then another one here, another one at the top. So they are arranged in these islands. They're not arranged in a sheet. Number one. Number two, something that you have to focus in the center. So the center appears very, very pink. And why is it so pink? What does the squamous epithelium produce? The squamous epithelium produces keratin, right? So that entire keratin, if a normal epithelium produces keratin, cancer will produce more of keratin. That is how a cancer works, right? Functionally, a cancer is similar to where it arises from. So squamous cell carcinoma will also produce keratin. And this keratin, do you notice it has this round and round configuration? Let me show you in a further higher magnification. So do you notice this keratin in the center has this particular configuration? It is round and round. What do you call this? This is known as the keratin pearls, and that is how you pick up a squamous cell carcinoma. You will be able to appreciate keratin pearls. Now that is one cancer. The other cancer that you have for esophagus, all of you know, that is adenocarcinoma. Before I go on to the pathology and how to identify an adenocarcinoma, what you have to know is that, see, the normal epithelium of the esophagus was squamous, so the cancer that could easily arise was squamous cell carcinoma. But here I'm talking about another cancer, which is adenocarcinoma, which the word adeno, basics of neoplasia, guys, the word adeno reminds you of glands. So now, from where did this glandular cancer arise? Remember, we just discussed the image of a disease called Barrett's esophagus, where the squamous epithelium was undergoing a change and undergoing a metaplasia into glandular epithelium, correct? So can I say that when a cancer arises in that changed, in that metaplastic glandular epithelium, that is going to be this adenocarcinoma. So very characteristically all over here, guys, you can appreciate glands that are infiltrating the stroma. Let me show you a higher power of the same. So here you can appreciate this is one single big gland that I want you to know. You can see this round gland with a lumen in the center. So this is the kind of pattern that you will see when we are talking about an adenocarcinoma. So two tumors, how will you identify them? When I'm talking about esophageal squamous cell carcinoma, the way I identify it are these islands of cells and they are going to have keratin pearls. Number two, when I talk about the glandular epithelium, when I talk about adenocarcinoma, what you have to look out for are these glands, and that is how you will identify an adenocarcinoma of the esophagus. So these were the two tumors that you have to know. So the main tumors and the main lesions, in fact, of the esophagus on which you get questions pertinent to images are achalasia cardia. Number two, you have the famous Barrett's esophagus, and number three, we have tumors of the esophagus, that is squamous as well as adeno. So we've done the main pictures of esophageal pathology. Now let's quickly go on to gastric pathology. So beginning with the gastric pathology pictures, all of you know that one organism that causes most of the diseases in the stomach is H. pylori, Helicobacter pylori. And this particular organism, guys, this bacteria is not only going to cause inflammatory disorders like gastritis and peptic ulcer, but it can also cause cancerous disorders. And all of you know that the two cancers which are associated with H. pylori, both of them are in the stomach because this requires an acidic medium. And those two are number one, gastric adenocarcinoma, the most common tumor of the stomach, the most common malignancy of the stomach. So one is gastric adenocarcinoma and the other one is a lymphoma of the stomach, that is maltoma. So we are going to see pictures of maltoma and we are going to see pictures of a variant of gastric adenocarcinoma as well, which are actually image based questions that you get. But before jumping onto that, let's see a picture of H. pylori. So now when you get a gastric biopsy and you want to do the diagnosis of H. pylori, so you have to put a special stain, and this is one of the most commonly asked questions. So over here, guys, all of you can appreciate that in the lumen, we see a lot of black color rod-like organisms, a lot of these that are spread everywhere. Now this is H. pylori, but why have they stained black in color? Why does the lumen show most of the blackish organisms? Because we've used a stain called the Warden Starry Silver stain. And that's the question that you get. The special stain for H. pylori is Warden Starry Silver stain. Now that's when you get a biopsy. In fact, guys, there's another test which we study in microbiology, which is again done for H. pylori, and that is known as the CLO test. What do we mean by CLO? CLO stands for Campylobacter-like organism. So that is CLO, Campylobacter-like organism. And this actually exploits a very important aspect of H. pylori, that H. pylori is a urease producing organism. So all of you have read in medicine and in microbiology that H. pylori, for the diagnosis, we do something called urea breath test. Why do we do the breath test? Because this is again a urease producing organism. Similarly, in a test tube, in a laboratory, we can do the CLO test because that is also testing the same. And what is the color that you have to keep in mind? Remember the pink color. So a positive urea test or a positive flow test will give you a pink color change. That's something which is very important for you to know from microbiology point of view. Okay, so having discussed the organism, now let's start one by one with diseases of the stomach. So the first disease that I'm going to show you is something that puts you in a fix, because now if you notice that there's something peculiar happening here. This is a gross picture. So the stomach has been opened up and put up in front of you. So what do you see out here? Something very interesting, that the stomach out here looks like an altogether different organ. Everyone agrees that if you would just have a glance over this picture, in one glance it would appear like the brain, like the sulci and the gyri of the brain. So can I say that the stomach now starts looking like this brain? So what do you call this disease? This is seen in a disease called the Minotaurs disease. And to simplify it, basically everyone knows that the stomach has gastric rugae, right? Now those gastric rugae in this disease, in Minotaurs disease, the gastric rugae are becoming extremely prominent. How prominent? You call them the cerebriform appearance of the gastric rugae, because they've started looking like the brain, or cerebriform appearance. So this is the cerebriform appearance of the stomach, which you see in Minotaurs disease. Although this is not a theoretical question based session, but there's one question I would want to put up to you. I hope all of you remember M for Minotaurs disease and M for males. This is seen more commonly in males. Secondly, when you look at it under the microscope, these all these cerebriform rugae that you're seeing, when you take a slice and you put it under the microscope, which is the most predominant cell population that will be increased? What is that cell? The foveolar cell. So you will see increase in the foveolar cells. And lastly, this is a type of a protein losing enteropathy. So a couple of quick questions that we've discussed, but this image, guys, is very important for the exam. Just remember that the stomach starts looking like the brain, and that's the Minotaurs disease. Moving on to the next image. Now over here, we've got another picture of the stomach, but now the stomach is started looking like another thing, and that is this leather bottle. So very clearly you can appreciate, like I've tried to put up a leather bottle out here. And what am I depicting with a leather bottle? Why do I call this leather bottle appearance? Because the leather bottle is very stiff and rigid, and that is how the stomach is becoming. So the stomach out here, if you focus on this entire wall of the stomach, do you notice it seems as if, it is thickened and it is whitish? This is because something is infiltrating into the wall. Similarly, if you see out here, the wall everywhere appears whitish and thickened. Something is infiltrating. Also, if you see in the lumen, you cannot appreciate those classical gastric rugae, right? You cannot. So they've been flattened out because something is constantly growing in the stomach wall, making it thick and rigid, just like a leather bottle. So what do you call this? More technically, you call this linitis plastica. And I hope all of you can appreciate and you can recall that linitis plastica was something seen when we were talking about a tumor of the stomach called diffuse gastric cancer. The word tells you pretty much everything about it. It's a gastric cancer and diffuse type. So by diffuse, I mean all of it is going to infiltrate diffusely into the stomach. And that is what you see. Now let me put up one question to you, because that's our next image that we've got. When I say diffuse gastric cancer and I say it's showing me this linitis plastica type of an appearance, what does it show microscopically? Which type of cells does it show microscopically? I hope all of you got that. It shows us the characteristic signet ring appearance. And that's the next picture that I've got for you. I don't want to point out any one cell over here, because this is a field full of signet ring cells. All the cells that you see over here are signet ring. Let me just highlight or, zoom into any one of these. So look at this cell, which I've tried to enlarge it, these two cells out here. So let's say take this one out here. So what do you see in this cell? Normally, whenever I make a cell, I make the nucleus in the center. Let me try to show you in a diagrammatic manner. So whenever I make a cell, this is what I do. Normally, I draw the nucleus in the center. So very clearly you can see out here, the blue color nucleus is in the center. On the contrary, what do you see over here? The nucleus has been pushed to one side. So do you notice the nucleus out here, the blue color nucleus is right at the periphery? Because what is the cell filled up with? The cell is filled up with this blue color mucin. So there is no space for the nucleus. The nucleus has been pushed to one end. This is what you call as signet ring. And what's the reason for a signet ring? Because the cell is filled with mucin. Now let's get back. What do you call this? You call this a signet ring cell. Because guys, this is how we define a signet ring. Break the term, it looks like a ring and all of us agree it was looking like a ring. Signet actually means signature. So do you notice I've just tried to bring up one GIF out here. So you can see that there is a particular pattern that is there on this ring, right? There is a pattern that you see on this ring. So when you place it in ink and you stamp it on a paper, you will see that pattern on the paper. So it's like putting a signature. Agreed? So this is exactly what this tumor and this cell is telling you. This signet ring cell is telling you that this is filled with a lot of mucin, and this is something seen in this particular cancer of the stomach. So now correlate whatever you've done with this picture. So do you notice you have this cell, the nucleus is right up pushed to the periphery, and this entire cell is filled with mucin. That's the signet ring cell which you see in a diffuse gastric cancer. So how will you get it in the exam? This is the picture. This is the picture that you will be getting in the exam without obviously the labelings and the high power view. And I hope all of you can appreciate that this entire picture, this entire full view, field full of signet ring cells. And how do I correlate this with the gross finding? Grossly, we see linitis plastica, the classical leather bottle appearance. Okay, now let's move on from here to another tumor of the stomach. Now beginning with the next tumor of the stomach, and that is a maltoma. First and foremost, what is the full form? It is MALT, mucosa associated lymphoid tissue. So this is a tumor arising from the lymphoid tissue. So basically in simple terms, this is a lymphoma. This is occurring in the stomach, which is actually the most common site of a maltoma. And this is the picture that you'll get. So first I want you to identify the picture that we've got out here. So look at the different parts. So do you notice at this extreme end, you can appreciate these round epithelial structures in the stomach? And then the rest of the slide out here, as you see, it is extremely blue. The rest of the slide is extremely blue because these are all the lymphoid cells. Now, there is something that you see with this yellow arrow that I'm trying to point towards, right? So something that you see out here, what is it? And I'll show you a higher power picture which will help you appreciate it better. So do you notice there are two types of cells that you're seeing out here? One are a little bigger and one are the smaller, the lymphoma, the lymphoid cells. So let me show you what exactly is happening here. The epithelium is being invaded by the lymphoid cells. So what is the term that I've used out here? I call it lymphoepithelial lesion. So break the term. Lympho means lymphoid tissue and lymphoid cells. Epithelium means the epithelium of the stomach. So lymphoepithelium, both of them are going to come up together. See a better and a higher view picture of the same. So here what do you appreciate? Again, this is still not the highest power. I will zoom into it further, but train your eye to pick up something at this power because you never know, the examiner might give it to you like this. So look at this gland that you see at the bottom. And do you notice it is infiltrated by these lymphoid cells? See a higher picture of the same. So here all of you can very well appreciate now that I've got this round gland present, and here I can see that there are these handful of tumor cells which are infiltrating into the glandular epithelium. So lymphoepithelial lesion, LEL, is how they write it in the exam as well. And this is the most characteristic microscopic feature that you see in a maltoma. So just to bring up one or two quick theory questions before we end, I hope all of you remember maltoma was associated with H. pylori, the bacteria, and that's just one form of maltoma. There's another form of maltoma which has nothing to do with this bacteria but to do with genetics. And which translocation? It's translocation 1118. 1118 for maltoma. So I think it's regardless to say that the one that arises because of H. pylori would give you a good response to antibiotic therapy. Obviously, the one that is not associated with H. pylori will not give you a good response with antibiotic therapy. So that's a very important lymphoma of the stomach, that is maltoma. In fact, The most common site of a maltoma, if someone asks you, the tumor arising from malt, the most common site of a maltoma in the body is actually the stomach. So guys, quick revision. In stomach, you have to know disorders like when the stomach starts looking like the brain, that is the Minotaurs Disease. When the stomach starts looking like a leather bottle, that's Linitis plastica. Then amongst the tumors, you have to know two very important images. One is of the Signet Ring cells and the other is the lymphoepithelial lesion that you see in a case of maltoma. So with this, we finished two very important organs, that is esophagus as well as the stomach. The next part of GI path that we are going to start with is going to be intestinal pathology. So under intestinal pathology, we will cover again non-neoplastic and neoplastic and a good chunk of images coming your way.
So hope to see you all in the next Tuesday session at 8 p.m. on the same platform of Unacademy Live NEET PG YouTube channel, and the next time on Tuesday we will be discussing all the intestinal pathology images. So hope all of you enjoyed this very short brief session on images in pathology. So we will continue to bring up these sessions regularly and we will be going chapter wise so that this part of pathology is sorted for you. Thanks for joining in, guys. Good luck and keep studying.